Hello and welcome to the lecture on medications. This is chapter 8 in the Miller book. Oops. So the objectives we're going to look for when we're talking about medications in the older adult, the first one is to examine age-related changes and risk factors that affect the action of our medications in the body, and also to assess the skills that are involved with taking medications appropriately. The second objective is to discuss considerations about herbs and other bioactive substances that could interact with our prescribed medications. And the third objective is to describe the purposes of a medication assessment and explain how to perform a comprehensive medication assessment. So talking about medications, first we must consider all sources of medications. This includes prescriptions, over-the-counter medications, herbals, and homeopathic substances. And so when we're asking the older adult what medications they're taking, we should really use these words specifically, because a lot of times we must remind them that we don't just want to know about prescription medications, we want to know about everything, because any substance that's going to be absorbed and go through pharmacokinetics in the body, so absorbed, metabolized, that's all going to interact together. So it is important for us to take a comprehensive medication history. So anything they're prescribed, and then specifically ask them, well, do you take anything to help you sleep? Do you take anything for allergies? When you have a cold, when you have pain, what do you take any medications like that? Because they might come up with different herbal medications and other over-the-counters that are going to give us a red flag that could have a potential adverse reaction together. So again, we want to remind them that in order to give them the best possible care, it's important that we know all of the substances that they're taking. Most people believe that if a substance is not a prescription, that they don't need to include that. So I just really want to stress the importance of asking specific questions, because even those non-prescription can be detrimental to the overall health promotion that we're trying to do. So herbs, they're considered dietary supplements. And because they're considered dietary supplements, they're not put through the FDA rigor as far as testing for safety or efficacy of the drug components, and with as much as the marketing as other FDA approved prescription drugs are. However, interactions can and do happen between herbal medications and other prescription medications, or between herbals and herbals. So many adults actually spend a good amount of money on herbals and other homeopathic products, and they just need to be educated on the pros and cons. So we don't need to necessarily stop all herbals and tell them that that's not appropriate, because as we learned with our cultural assessment and the diversity of older adults, we want to work with patients, we want to promote health, but we do need to be cognizant of the practices that they believe in, and so that we can intervene so that nothing bad happens, that no adverse reactions occur, and that we can maintain a healthy, active lifestyle for them. So again, educating on the pros and cons, and to not discontinue prescription medications without their provider's knowledge. So in the book, there's a lot of different tables, but table 8.1 and table 8.2 go through different drugs and herb interactions and what could potentially occur with different types of herbs. So next we're going to talk about age-related changes and how medications, how age-related changes affect the action of our medications. When we look at medications, the effects can be related to the pharmacokinetics and the pharmacodynamics. So when we think back of when we took pharmacology, the pharmacokinetics of a drug is how it is absorbed, how it is metabolized, how it's distributed, and how it's excreted. And then the pharmacodynamics are those effects that we're looking for with the medication. And so there is age-related changes that is related to a decreased glomerular filtration rate, and a decreased clearance rate in our older adults. And these are going to be greatly affecting the pharmacodynamics of our medications, because as a body isn't able to clear those metabolites of drugs, those byproducts, the drug itself is left to kind of stew inside, and our serum levels increase. And then we have an increased toxicity to those medications. So this can be related to the drug half-life. So it takes about 5 half-lives for a drug to be completely eliminated from the body, or for its effects to be null. And so again, if we can't clear that, the half-time can increase, causing toxicity. So looking at a drug's half-life and looking at our clearance rate is going to give us an idea of if drugs are going to potentially be increased to levels that are unsafe in the older individual. Speaking about hepatic metabolism, this is done mainly by the cytochrome P450 system. And it's so important when we look at this P450 system because many drugs are metabolized through the cytochrome P450. And so if we have competing sites through that method of metabolism, this is where we see drug-drug interactions. And so one drug is going to compete or have a higher binding capacity, and the other drug will then increase. So we wouldn't be able to metabolize it. So again, it would lead to toxic levels of a certain drug depending on the competition through there. And I recently went to a webinar talking about statin therapy and the older individual, and statins are also metabolized through our P450 enzyme. And when we look at the older adult, we need to make sure that we're using the lowest doses of our statins so that we don't have the myalgias and up to the rhabdomyolysis that we can see with statin therapy. Other major drug classes that use the cytochrome P450 are psychotropic medications like Haldol and benztropine, as well as antidepressants. So adverse drug reactions can occur for numerous reasons. Again, we just covered some basic ones here about the decrease in glomerular filtration rate, the decreased renal clearance, hepatic metabolism, the P450 enzyme, but others that can increase the toxicity of medications would include frailty of the older individual, malnourishment or dehydration. We know that as we age, we actually have a decreased amount of free water, which leads us to risk for dehydration easier, but also leads us to increased drug toxicity. The multiple illnesses, especially chronic illnesses, can set a patient up for adverse drug reactions, because as we try to treat multiple illnesses, we are adding medications upon medications. So it really becomes a collaborative effort to make sure we are safe with prescribing drugs. Any illness that interferes. So on top of chronic disease, we can have acute on chronic diseases. So this is going to further impact cardiac, renal, or hepatic function, leaving toxicity and drug-drug adverse reactions at high risk. Cognitive impairment can also be a reason for age-related changes in our medications, and this is more related to the functional ability to take medications as prescribed. You know, do we remember to take them? Do we know how to take them appropriately? And a few other factors then would be history of medication allergies or adverse effects, so inability to comply with the medication regimen, and recent changes in functional status, which again goes, are they able to physically take their medications? Do they have dysphagia? So now we can't ingest the medication appropriately. And lastly, the highest risk medications that I want to throw out there that we want to look at closely in our older individual is going to be anticoagulants or antiplatelets, antidiabetics, NSAIDs, and any drugs that affect our central nervous system, such as anticholinergics. So if you remember nothing else from this slide, think about how Anticholinergics are contraindicated in an older individual because of the cognitive and functional disabilities and the increased risk of delirium. And then also remember that the age-related changes such as decreased glomerular filtration rate and decreased renal clearance is really what sets us up to have drug toxicity. So what behaviors are going to influence our medication taking ability in the older adult? Well, going back to the last slide, the medications themselves can set a patient up for cognitive and functional decline, such as our antipsychotics and our anticholinergic drugs. But other behaviors that are going to affect the use of medications include the patient's level of motivation, their knowledge about why they're taking these medications, why they're important, what are we looking for to evaluate, and cultural and psychosocial influences. Another risk factor for medication taking behaviors is the cost and accessibility of those medications. With the development of Medicare D, it's not actually part of the Medicare services that are covered by the government. It's a kind of fill the gap private insurance that older adults still need to pay into. So it's in addition to other choices like housing, food, safety. Can they afford these medications? Can they get to the pharmacy to fill these medications? Do they have transportation? There's so much that goes into the psychosocial and the socioeconomic pieces of cost and accessibility to the medications. And the last bullet point there speaks to the functional capabilities of the older adult. Can they read and comprehend the directions on the pill box? Is the prescription container, is it big enough to be able to actually read those instructions? I know there are some like medication bottles out there where it comes with an audible, take once daily. And I've never actually seen one, but I've heard about them and I would love to get my hands on one and actually see what it looks like. But going back to the patient, can they remember verbal instructions? If we tell them cut this pill in half, are they going to do that? Can they remember that? And do they have severe arthritis where they could even open up the bottle, take it out, put it in a pill box, or push down with the scoring and actually half that pill? Are they just do they have dysphagia? Do they have decreased GI motility, things that are going to impede their ability to swallow? And what other functional behaviors might they have? I'm sorry, not functional behaviors, but functional disabilities might they have that are going to limit their ability to have good medication adherence? Let's talk about other barriers that are impeding the older generations and our older individuals to take medications or to be prescribed medications appropriately. And so there's numerous myths and misunderstandings out there that are going to influence attitudes of the adults and caregivers and healthcare practitioners. And even though every age can be influenced by these myths and misunderstandings, our older population, to a higher degree, kind of lives with this stereotypical idea of normal changes of aging, which actually aren't normal at all. So talking about some of these myths, many people think that over-the-counter medications are always safe. That they don't need to be prescribed by a doctor, so I don't need to double check that this is okay for me. When in reality, when we talk about anticholinergic drugs, one of those drugs that's over-the-counter is Benadryl. It's a first-generation antihistamine, and patients can take it for itchiness, allergies, sleep, whatever that they take it for, and usually there's no problem in the young, healthy adult. But unfortunately, we're talking about older individuals who have a decreased renal clearance, they have a decreased filtration rate, and they have competing binding at that CYP450 enzyme for metabolism. So these type of drugs can actually set a patient up for delirium, confusion, right? Acute mental status changes. And lo and behold, they end up in the ER, right? So over-the-counter medications are not always safe. So that is a big myth, and why we go back to our comprehensive medication assessment of our patient and all of the medications that they're taking. Another myth is that medications can just be a quick fix. So a 77-year-old woman comes in with overactive bladder. She's going frequently. She, needs to be near a bathroom all the time. It comes in such a hurry, and we give her some oxybutynin, right? We give her some diazepam. We're gonna fix that problem for you, right? But we don't actually do a full evaluation, and we don't look into why this is happening, because again, that is not a normal age-related change. So we must identify those older adults, what their belief is, what their norm is, and act in an individualized approach to combat these misunderstandings. Some of the communication barriers that we have, maybe coming from the older adult to the healthcare setting, is that they don't ask questions. They maybe, because of these myths that this is a normal change that they should undergo, they don't want to look ignorant. They have this respect for healthcare givers and for physicians. So they're reluctant to challenge a prescription that a doctor, a person who is esteemed, tells them to take. So reluctant to defy authority in a way, fear of looking stupid. They also might have some hearing or vision impairments, which are impeding the education that we're trying to do with them, as well as what kind of behaviors or communication is that healthcare provider giving off? Are they short with the patient? Are they, a little overly persuasive of using prescription drugs? Are they, and I don't know if I already said this, dismissive, of their fears? Well, then those are all signs of bad practice. So we want to make sure that we're giving time and really looking at our patients again as individuals with problems that we can not do a quick fix, but look into and see why it's happening, what we can do to make them more comfortable, to make sure it's safe, to increase functioning, and to increase independence, increase that feeling of community and being involved and being healthy. So I guess I could just use the word wellness. How can we promote wellness with our patient? Fortunately for us, there has been many tools that have been developed for improving prescribing practices, and helping make those decisions on appropriate medications for older adults, to help us decide what medications can be stopped and what medications should be started for the older client that we are seeing. Because inappropriate prescribing practices poses a lot more risk than benefits to the patient. So some of these tools are the Beers criteria, and this has a big list of medications that should not be prescribed in older individuals. And if you remember the big one that I said there, it's anticholinergics, right? We do not like that type of drug in the older individual because of the increased risk for delirium. And other antipsychotics, not a good choice for older individuals. So the Beers criteria is a great tool to help practitioners decide on the best regimen for their patients. The other tool that's evidence-based and really helps the prescribing clinician decide what to start and what to stop when looking at a long list of medications is that stop-start criteria. And this came from the Harvard Institute for Geriatric Nursing. And it can be used in conjunction with the Beers criteria, but it's just another guide. So in addition to telling a prescriber to stop a medication, the start part, which is different from the Beers criteria, is that it will identify drugs that maybe should be used instead. Part of the reason that we've had to come up with these tools like the stop-start criteria and the Beers criteria is because of the phenomenon, or not the phenomenon, but because of the practice of polypharmacy. 10 years ago, 15 years ago, we used to say polypharmacy is having a prescription drugs of 5 or more. But unfortunately, people are living longer, chronic diseases are being managed better, cancer survivors are staying in remission longer. So that 5-drug rule is kind of old and didn't quite work. So now we are saying that polypharmacy means that there is the use of more medications that are clinically indicated. And so the stop, start, and the Beers criteria are useful to help combat the polypharmacy, which can lead to adverse medication reactions. So medication non-adherence is just not taking meds as prescribed. So having a change from different prescribing practices. So let's say we tell you to take this oral medication, half a pill twice a day, and so the patient misses a dose, doesn't take one for a few days, tries to make that last longer than halves the half, right? So they're taking too much, they're taking not enough, or they're just not taking it appropriately. That's all lumped together as a medication non-adherence. And this can be related to financial concerns, such as the cost, again, related to how much the drug is, if they have insurance, if they don't, if they're on fixed income, if it's a trial drug, if it's a new drug, is it brand, is it generic? I mean, there's so many financial concerns that can come out of medication management. And it also can be related to insufficient recognition of adverse medication effects. And this is more of a phenomenon, I would say, because let's say a patient comes in with some complaint. Let's say it's sleep, right? I'm not sleeping well. Okay. So instead of looking into why aren't we sleeping well, let's do a comprehensive H&P and physical assessment and figure out why we're not sleeping well. The doctor says, great, here's a medication to help you sleep. A week later, the patient comes in with concerns for altered mental status. So now we're prescribing a med for one issue that's maybe not fully developed, and it's causing another issue. And then the cascade keeps occurring because now that they're coming in with altered mental status, now we're looking at memory type drugs or antipsychotics or depression medications, when really it all goes back to two visits ago, not identifying the actual problem. So I have a few questions here. Which risk factor may have a negative effect on bioactive substances in the older adult? So looking through these, we're looking for, in bold there, the risk factor, right? So what's going to increase our risk for adverse drug reaction? So looking at it, appropriate prescribing practices. Well, that sounds good. It's not going to be that one, right? Increased prevalence of chronic conditions. Well, looking at that, yes, that definitely is a risk factor because we're going to treat those chronic conditions. They're going to be on more than a few medications for it. So right now we're thinking it's B, right? How about C? Knowledge of medications. Knowledge is power. So that's good. So that wouldn't be a risk factor. A and C are not risk factors. Those are good things. We're looking for risk factors, which is going to be a detriment, right? Avoidance of over-the-counter preparations. In this instance, that would not be a risk factor because this means that our patient is not just thinking every OTC is safe and they're going to ask their doctors before they're starting it. So for this question, which risk factor may have a negative effect on bioactive substances? It's B, increased prevalence of chronic conditions. Pathologic conditions not only influence the action of substances in the body, but also contribute to non-adherence, especially in combination with functional limitations. Which med is inappropriate for use in the older adult population according to the Beers criteria? So we have NSAIDs, anticonvulsants, opioid analgesics, and anticholinergic drugs. And I really, really hope you guys are thinking like, I got this one right away. Excuse me, because this one would be D. Using the Beers criteria, it identifies medications that are inappropriate for use in the older adult population because they are either ineffective or they have poor safety profiles. Anticholinergic drugs or drugs with anticholinergic property are inappropriate because of the toxic side effects, which are correlated with delirium, agitation, hallucinations, other altered mental status, cognitive impairment, but they can also increase the risk for seizures, arrhythmias, and urinary retention. Okay. Mrs. N is prescribed a complex medication regimen for the chronic condition of diabetes. In addition to the prescribed regimen, another factor for non-adherence may include what? So again, we're looking for risk factors for non-adherence. So something that's going to cause a negative outcome. Okay, so in Mrs. N is living with her daughter going to promote non-adherence? Is knowledge of the medications going to promote non-adherence? Are adverse effects of the medication going to promote non-adherence? Is being cognitively well, being aware, being alert, going to promote non-adherence? So sometimes just rewording how we're thinking of a question can help us. And so in this question, the answer is going to be C. The adverse effects are going to be a factor for non-adherence. So again, non-adherence refers to the medication taking behaviors that differ from the prescribed pattern. So this can be missed doses, failure to fill a prescription, or taking a medication inappropriately. Other factors that contribute to non-adherence could be depression, isolated living situations, financial concerns, the adverse medication effects that we're seeing here, and or a complex medication regimen. So what are some of the medication interactions? We're not going to talk about specific, this drug causes this, but we're going to talk about general terms and kind of some, maybe one or two examples in each category there. So talking about medication interactions, medications interact with any other substance that is bioactive within the body. So we can see on this slide here, med herbs, meds nutrients, meds alcohol, meds nicotine, all these things that we're going to ingest, digest, inhale, they're all bioactive to us, and they can all, cause an adverse effect. So med interactions, when we're talking about those, the adverse reactions from medication to medication actually can increase exponentially related to how many drugs are prescribed to a patient. And because medications usually take several medications at the same time, they are at increased risk for having medication interactions. I encourage you to check out table 8.4 in your book, and it talks about some specific med interactions. But again, it's going to be impossible for us to talk to all of them. But if we think about two maybe of similar drug classes and how those can interact together. So if we take a calcium channel blocker and we take a beta blocker, the potential of having a hypotensive effect is very high because of that med interaction. Another one is medication and herbs. So we briefly discussed this prior in the lecture here. And one of the major drugs that is affected greatly by nutrients and herbs that we intake is warfarin or Coumadin, which is an anticoagulant. So we know that ginkgo, ginger, and what's the other one? I can't remember. But ginkgo biloba and ginger, those are going to have some major effects on our not major, but potentially major if we're taking Coumadin at the same time. It's going to increase the toxicity and increase the effects of Coumadin. So we have to be very careful when patients are taking the warfarin sodium or the Coumadin, however you like to call it, that we know everything that they're taking because there's such big impact there. Another one with medication and nutrients is grapefruit juice. There's a lot of different medications that if we take it with grapefruit juice, again, like our statins, it's going to increase the availability of that statin in the bloodstream and increase adverse effects. Medications and alcohol. We want to let patients know that they shouldn't take alcohol with opioids um, or other narcotic analgesics because it's going to increase that depressant CNS depressant effect. And then lastly, medications with nicotine can cause us to maybe need more of our antihypertensive medications or could cause some increased anxiety, agitation, suicidal behaviors combined with some of our antidepressant medications. Here's that table I was showing you about, but the main points then in going through table 8.4 is to remember that the medication interactions are influenced by the number of medications taken. So the more meds we're on, the more risk for adverse effects. When we talk about the toxicity, we're talking about serum levels. So if there's an increased serum level of a drug, that means it's going to have a higher effect or the pharmacodynamic in the body. And again, one major example is Coumadin or warfarin sodium. Summarizing medication and herbs, again, the FDA does not regulate the sale and the marketing of herbal, I don't want to say medications, of herbs, and because they're considered a dietary supplement. Dietary supplements, though, contain a lot of ingredients such as vitamins, minerals, and other botanicals. And research has shown that there's many health benefits of taking some dietary supplements, but it also has not proved that there's any benefit to certain herbal medications as well. And so to use dietary supplements safely, some key education points that we should bring to our patient is going to be to read and follow the label instructions and recognize that natural doesn't always mean safe. To be aware that herbal supplements may have different compounds or the ingredients might not all be named because they're not FDA approved. Some dietary medications definitely can pose a risk, especially medication herb, like we talked about with the Coumadin, and there's a list of others that can be sensitive to certain herbs. But also for surgery, many of our herbs have some anticoagulative or pro-inflammatory effects, which can be detrimental during surgery. So most physicians are going to say to stop all herbal medications for at least 2 weeks prior to surgery to prevent complications. Also, most dietary supplements, like a lot of prescription medications, haven't been tested in special populations like pregnant women, nursing mothers, children, and the very old adults. So we don't really know how they're going to affect our older population. And so generally, again, we want patients to tell our healthcare providers about any of that complementary herbal medications, herbal supplements, and dietary supplements that they use so we can help them determine if it's safe for them or how we can incorporate their beliefs into our medication promotion. Nutrients can be considered food, beverages, or tube feedings, as well as dietary supplements. And these nutrients can have serious consequences as in the way of we might have delay or diminished absorption within our GI tract. Here's table 8.6 as far as medications related to how they interact with alcohol and nicotine. One fairly common reason that we might have adverse reactions with medications and alcohol is that oftentimes we just either don't ask about their alcohol consumption, or if we do ask, the patient may not give a truthful answer, or usually answers with a little bit less than what they actually take in. And so we don't have a good estimate on safety there. We've talked a lot about risk factors and how that can lead to functional consequences within the older adult. So here is a large view overview of what we need to consider when prescribing medications for our older adults. The first one is that medications need to be monitored more closely in older adults because of their altered therapeutic effects. And again, that is related to a decreased GFR and a decreased ability to metabolize through the CYP450 cytochrome, and decreased renal excretion of our metabolites. So those three big reasons with excretion and metabolism is why we're going to have those altered therapeutic effects. The next one is that increased potential for adverse effects, and we talked about a lot of reasons for that. And one to be included of the more drugs that we take, the more risk for having an adverse effect, and then the potential for adverse effects with all of the other herbals, nutrients, alcohol, nicotine, all of those. Increased anticholinergic adverse effects. Again, this is detrimental for our older population because they are more susceptible to the anticholinergic drugs. And this increases our risk for developing delirium, which is a major impairment of cognitive ability in older adults. And that goes into our altered mental status, that through any medications, our older adult is at increased risk for medication-related altered mental status. And again, it takes a close observation analysis, and it takes time to look at a prescription and the polypharmacy to determine what's safe for our older clients. Back in the 80s, we really started looking at antipsychotic use in patients with behavioral issues related to dementia. And back in 87 was the Nursing Home Reform Act that really made us look hard at the use of antipsychotics. And so we used antipsychotics like Haldol to deal with behaviors related to dementia. So then we started making these second-line or atypical antipsychotics, which are still used quite often for behavioral issues related to dementia, but they still really aren't the best. And so we try more environmental changes and supportive care for our patients with dementia. There is still a role of the second-line antipsychotics in helping with behaviors, but again, it's not the best practice anymore. And so some of those drugs are like our Geodin, Seroquel, to help with agitation and other type wandering. And so these come with their risk as well, which increase our risk for falls, fractures, seizures, strokes, arrhythmias, MI. So there's quite detrimental effects of antipsychotics when we use them in our elderly patients. And lastly, a functional consequence related with some medications in older adults is tardive dyskinesia and drug-induced Parkinsonism, I'm sorry. And these are also related to our antipsychotic medications. So tardive dyskinesia is manifest with these rhythmic rolling type movements that we usually see in the mouth first, kind of like moving of the tongue, moving of the lips, but it can lead into kind of more tremoring and rigidity, where the drug-induced Parkinsonism is reversible as related to our drugs, but we're going to have rigidity, risk for falls, and musculoskeletal pain. So let's review a couple more. An 84-year-old gentleman has been admitted to your unit because he is not taking his medications as prescribed by his primary care physician. He has been having ongoing problems keeping his diabetes and blood pressure under control. So what data would the nurse need to gather based on this information? Information that we'd need to know would be see if they know the knowledge or have the education or have the hindsight about why the purpose and dosage of medications, right? Does he know why he's taking them? Does he know how much he's supposed to be taking? What are cultural or psychosocial influences affecting administration? Does he have a certain diet, that he follows at home, or that someone cooks for him, that's influencing his ability to manage his diabetes and his blood pressure. Other functional questions that we can ask is, does he have the ability to read and comprehend directions? Does he have any sensory hearing impairment that's impeding his education or ability to follow directions? Is he able to swallow the oral preparations? What might be the reasons? We really want to take a deep dive into his reasons why we're seeing this medication non-adherence. And what questions could we ask? We could ask, do you have friends or family that can assist? Is there anyone that can stop by and do some checks to see if you need anything, to just kind of double check that your medications are being taken? Do you have a pill organizer, either weekly or bi-weekly? And what are some rituals that maybe we can ask about to promote adherence, to see when do you wake, when do you sleep, when do you eat, and maybe we can incorporate those medications at times of a routine that he does daily to promote consistency. And so these are the answers that I just went over there, spoiler alert. And let's talk about our last objective here, the nursing assessment of medication use. So on the right-hand side, you can see our cascade, our inappropriate prescription cascade, right? So it happens, right? And you can totally see where it all falls together. And now look at how his medication list just goes and goes and goes. But in reality, we do want to assess medication use and assess those effects to keep our patients safe and at the normal level. And so some of our goals for completing a nursing assessment of medication use is to determine the effectiveness of that medication regimen, to identify any factors that interfere with the correct regimen, ascertain risks, detect those adverse medication effects, and then identifying any teaching needs with regard to the medications. First off, we want to have good communication techniques for obtaining this accurate information. The barriers that we talked about earlier with the prescribing clinician are the same type of barriers that we may have when talking to our patients about their medications and their medication adherence. And that can be that we are in a position of power, so that respect and that not wanting to sound ignorant comes in, so they don't want to maybe tell us about questions that they do have. If we don't specifically ask about any cultural, religious, or psychosocial beliefs that they have, we might not fully understand their reasons for taking or not taking a medication. We can address these barriers by asking open-ended questions in a matter-of-fact way that conveys a non-judgmental attitude during this medication interview. So we want to keep in mind the importance of asking about folk remedies, asking about herbal medications, and over-the-counter medications. So the scope of the medication assessment is listed there, as I named the goals earlier of our medication assessment. But another tool we can use besides good open communication is observing the patterns of how they use their medication. So for example, if you're in the home, you can ask them to lay out all of the medications that they take for you. You can ask them to bring their medications to a follow-up visit, and so that you can see what they have on hand. And even in the hospital, I've seen so many times where they come in with at least 2, 3, or 4 medications that either aren't on the list, it's the wrong dose, or it's something that they didn't disclose right away. By using this direct observation, we can assess functional capabilities, their ability to open the caps. We can assess their education, if they know what these medications are used for, and we can assess the level of adherence as far as, again, like the dosages and if they're taking them appropriately. Lastly, we'll talk about how to link this medication assessment to their overall assessment. So past and present medications, we can look and see it has, do they have a new complaint that maybe we have seen in the past. So let's say they were on 3 different blood pressure medications, and we're looking, they're having uncontrolled blood pressure right now. We can look back, did they stop, have they lost weight? Have they started an exercise regimen? And how do the current medications kind of relate back to their past medication use? Also identifying clues to problems or complaints as far as they're having a symptom that might be answered in the medication regimen that they have. As far as their functionability to take those medications, we can observe that home environment, look at their medication taking behaviors, and serve that health assessment serves at that basis for identifying many factors that can increase the risk of medication non-adherence. We also are able to look at altered therapeutic effects and adverse medications, so med nutrient, and med herbal medications. And so identifying these adverse medication effects, the first step in alleviating these medication effects is to recognize their existence, right? As a nurse, we are with the patient from the continuum. Sometimes the nurse practitioner role really is there from birth to death. We're there the whole time, whereas more physician clinicians are more inclined to acute illness and not as much as throughout the lifespan. So nurses are at a nice or at a pivotal role to find these adverse effects of medications and to talk to the patient about them, because we're more in tune to their day-to-day. We are more in tune to the holistic care, the personal care, and the individualized care that each person needs to maintain wellness.